Good morning, everyone. Let's get started. My name is Sara Gianella Weibel. My pronouns are she and hers, and I am an assistant professor here for the Division of Infectious Disease and Global Health. So today I will be talking about decreasing inflammaging by treating asymptomatic CMV. Of course, this is not something that that anybody should be doing in the clinic, but we have a couple of studies coming up where we are trying to do so. And so I will give you a little bit of background about inflammation and aging in a setting of CMV and HIV co-infection. And then I will talk about two ACTG clinical trials, 5383 and 5355, that I am the chair of, and both of them should be coming up hopefully in the next 3 to 6 months. So we are basically on the final stage of protocol development for both of them, and hopefully we will start enrolling late 2019 or early 2020 at the latest, hopefully. So just a little bit of background. So most people who live with HIV are co-infected with cytomegalovirus, and even if they have a good immune system with high CD4 T cells, they still experience frequent shedding of CMV, completely asymptomatic, and we don't really know the meaning of this shedding, but basically a lot of people living with HIV, if you collect them deep enough with oral mucosa and genital mucosa and urine, you probably will find some CMV DNA. And here is a study that I did with Sheldon Morris, where we showed that basically in Susan Little's primary infection cohort, if we sample people during the first year of infection, this is the blue one here, the CMV, 80% had at least one episode of detectable CMV shedding, despite primary infection, despite high CD4 T cells. So, and it has been shown in multiple studies from myself and also from others. Now, wait a minute, this is one step. So basically, CMV has this unique capacity to trigger a huge T cell response. So basically, CMV has been co-evolving with us since we were sponges, basically. And so it has adapted to our immune system in a unique way. And basically has this unique opportunity, capacity to inflate our T cells. Basically, and by the time somebody is older, almost half of the T cell repertoire is targeting cytomegalovirus. And these are just data from Louis Picker, where he shows, and these are also like in CD4 and CD8 T cell compartment in these people. Wow, sorry, this is not working well. So these are just random people without HIV, and basically they had a median of 10% T cells targeting cytomegalovirus. This is huge. Basically, it's one virus out of thousands, millions of virus. The T cells target one single virus, and we know that this is even higher in the setting of HIV or as people ages. And then, and this is what I was saying before, is that as I have a lot of data showing that cytomegalovirus is associated with inflammation, and that when you can detect replicating CMV at any mucosal site, there is increased inflammation in blood. And these are data from Mike Freeman, who is a friend of mine and a colleague in Cleveland. And he showed that basically people with HIV and with CMV have much higher level of proliferation of CD8 T cells and also of inflammation. And TNF receptor 2 was one marker that was particularly elevated in people co-infected with HIV and CMV. And I wanted to show this data instead of mine because we constructed the clinical trial basically around TNF receptor 2, and also because TNF receptor 2 has been shown to also correlate with non-AIDS event. And this is just a figure to summarize a little bit the model that I am going after. This is a figure that Scott Letender did for a review that we wrote a couple of years ago, where basically we say that CMV and HIV are working together to hijack our immune system in terms of proliferating of CD4, inflammation, senescence, and these will then create damage at the end organ level and worse outcome in general. So I want now to kind of touch the main organ system that are known to be affected by CMV, and one that is particularly important and well known is the cardiovascular effect. And this is well known from the transplant world, where a lot of research has been done, because of course when somebody has a transplant and people take immunosuppressant medication, CMV will replicate, and it has been, there is a lot of research showing that CMV replication in the setting of transplant are associated with cardiovascular disease. And there are multiple mechanisms how this might happen. First of all, CMV can infect multiple cells, and among those also endothelial cells and monocytes. So when there is, if there is CMV replication going on, and vascular endothelial cells are infected and monocytes are infected, and they all meet together and create inflammation, and they create vascular disease. There is also other mechanisms that are more indirect, where, for example, Steve Spector, who most of you might know, he's a professor here, has some very nice data showing that CMV-specific T cells have a special receptor that can attack endothelial T cells. So there is a whole body of research actually showing that cytomegalovirus is associated with cardiovascular disease. And in the setting of transplant, of course, CMV is treated routinely, because we know it is very bad for people when they have a transplant to have CMV, and they can get very sick. And so there are very old studies that show that not having ganciclovir is associated with a much worse outcome in people after heart transplant. And this again shows that there is probably some effect of herpes viruses, and we think CMV in particular on cardiovascular disease. This is a PET-CT, and I'm showing you this because as part of one of the clinical trial, we will propose to do PET-CT. PET-CT show inflammation in general in vessels, and this is a study from, again, like 7 years ago, where they showed that people with HIV have much more inflammation at vessel level. So you can see that this is people living with HIV. This is HIV negative. There is just much more red and yellow going on. This means more inflammation. And there was also an association between aortic inflammation and CD163, which is a marker of monocyte activation that again has been associated with CMV. So while we don't, so in this study they don't directly blame CMV for inflammation, there are evidence that CMV might mediate some of what they have seen here. And then multiple studies have shown association between CMV-specific immune response and marker of cardiovascular disease, like, for example, carotid intima media thickness. This means how thick is the carotid arteries. And you can see there is a positive association between CMV-specific CD8 T cells and thickness of the carotids. And these are all data from Priscilla Shu, who is working with me on one of the clinical trials. There is also another study that came up a couple of years ago, where they were looking at association with being CMV seropositive and non-AIDS event. So they did not see any difference in people that in AIDS event, because of course most people were treated and had a good immune system, but there was a significant effect of being CMV seropositive on non-AIDS event, and in particular cardiovascular disease. There was a odds ratio of more than double having cardiovascular events if people had also CMV co-infection. Okay, so as you can see, there are plenty of data, and this is only really a little part of it, showing that CMV is associated with cardiovascular disease. But what about other end organs? So one that we are particularly interested in is neurocognitive, of course, because that's a big part of our research. And even if there are not as many data connecting CMV with neurocognitive impairment, the data that we have are compelling. And these are, as I wanted to show you, just the data that we generated here in a paper from Scott Letender, where he basically showed that having the level of CMV IgG, this means the level of the immune response, is negatively associated with the T-score. I know T-score is confusing. I get confused all the time too, but T-score is worse when it's low, which is the opposite of GDS, which is worse when it's high. So basically here, so basically bottom line, CMV is bad for your neurocognition, and this is particularly bad in people who are on antiretroviral therapy. So basically, we seem to be an effect from CMV on neurocognition. What about diabetes? So why are we interested in diabetes? These are data that are unpublished that were shared from Christina Erlandson. And it looks like diabetes is by long the most frequent morbidity associated with HIV these days, now in the era of antiretroviral therapy and integrase inhibitors. So we were thinking, we were looking into is there any effect that CMV might have on diabetes, since diabetes is so prevalent. And honestly, there are data out there suggesting that CMV could have an effect also on metabolic disorder and diabetes in particular. First of all, diabetes increase in people after organ transplants. CMV is expressed a lot in adipose tissue, surprisingly, much more than I would expect. And we know the adipose tissue is an important modulator of insulin. There is adipose tissue, there is a infiltration of differentiated CD8 T cells that we know are the ones that are fighting CMV. And so basically putting everything together, we hypothesize that CMV might also play a role in diabetes in the setting of HIV. So this is a little bit more speculative, high risk, high reward. And this is why it's kind of a pilot study, but Merck, who is also donated the drug, was interested in funding it. And I will talk a little bit more about this in the past. So of course, CMV is not the only driver of inflammation. We all know there are multiple drivers. Inflammation is multifactorial. For example, microbial translocation, HIV replication or persistence is also a driver. But there are data suggesting that CMV interacts with all of these other markers of inflammation, as a driver of inflammation. For example, CMV might contribute to microbial translocation because CMV can replicate in the gut and then drive or enhance microbial translocation. This has been shown by Peter Hand and his team in PLOS Pathogen a couple of years ago. Also, and this is something that Davy and I have been working on since a long time, CMV seems to be associated with HIV replication and also with higher reservoir. So even if CMV might not be the only driver of inflammation, we think that it might be the most important, and it has also indirect effect on other drivers. So of course, everything that I showed you so far are all observational data. So we still don't know if CMV is the driver or if it's a cause of inflammation. Like which one is the chicken, which one is the egg? It's just people that have a lot of inflammation, they just might have a lot of CMV, or can we really blame CMV on this inflammation? And to really find that out, we need an intervention. Now, to be fair, in 2011, Peter Hunt already did a small intervention. Basically, he had it was only 30 patient study, and most of the study participants were not treated on antiretroviral therapy. And so they were replicating, and the study was only 8 weeks on valganciclovir. The reason why is because valganciclovir is a relatively toxic drug, and so you don't want to treat people for a long time on valganciclovir. But basically, this study showed that people that were treated on valganciclovir had a significant decrease in CD8, activated CD8 T cells. So this study kind of hints that CMV might be the driver of inflammation and not the other way around. Now, in preparation for this trial, Peter Hunt went back and generated some of the soluble marker, like soluble TNF receptor 2. Remember, that's one of our primary, but also CD163, which was associated with arterial inflammation, and CD14, which is an other marker of monocyte activation, and basically, as you can see, all three of them were significantly lower in valganciclovir-treated people, and some of them remained low even after stopping antiretroviral therapy. So basically, looking at the TNF receptor 2, which is one that we know a lot about because it was measured in multiple papers, this is like a 22% decrease in myocardial stroke and risk, and a 50% decrease in risk of diabetes mellitus, so based on the literature. So that's huge. That's more than any single intervention that has never been done in any ACTG study. So if this is true and we can reproduce that, that will be the single-handed most effective intervention that we can think about to decrease inflammation and end organ disease. Okay, and here I wanted to talk about the study. So study number 1, 5383, is a randomized placebo-controlled trial to evaluate the safety of letermovir in adults with HIV and asymptomatic CMV who are on suppressive antiretroviral therapy, and its effect of chronic inflammation, HIV persistence, and other clinical outcome. Okay, so the study name is crazy, but we call it ELICIT. So the co-chair are Peter Hunt and me, and Davis, the vice chair. Sorry, I should have written that down. Illicit, oh, illicit. And I'm not even sure how we came with illicit. It was not my idea. It was like evaluate letermovir or something like that in CMV, inflammation, and T. What is the T? I don't know. Who knows? Oh, ART. That's not, it was not my idea. Okay. So what is letermovir? Letermovir is a drug with who is sold by Merck. Sorry, Scott. And it is the newest CMV drug. It has a completely different mechanism of action compared to every other CMV drug. It's a DNA terminase complex inhibitor, and was recently FDA approved for prophylaxis of CMV infection in recipient of allogenic stem cell transplant. The reason why we have been waiting to do this study until letermovir is out and not with valganciclovir is because it's much safer. So here are the data from the original study on stem cell transplant patient, and you can see that the cumulative rate of infections is significantly lower in letermovir compared to placebo. There was also a decrease in mortality that was significant, and then the adverse events were even lower than in placebo, so which makes it a very safe drug. The most important adverse events are vomiting, edema, and then this is not very frequent, the flutter, but it's important enough that you will see when we designed our study, we had to exclude people with any sort of cardiovascular disease or risk of developing any tachycardia. So the study design, this is a phase 2 randomized placebo-controlled double-blind multicenter study. It's limited to the US only for the reason because we wanted to do the PET-CT, and this is very hard to implement. And also letermovir is right now not available anywhere outside the US yet. So it's a 1-to-1 randomization, 180 HIV and CMV co-infected study participant. Everybody needs to be on suppressive antiretroviral therapy for at least 48 weeks, and we allow some blips, and of course older than 18, but we have no upper age limit. So probably, so we project accrual and study duration, it's probably 3 years. The intervention is letermovir 480 milligram once a day, or placebo, of course, and we follow people for 60 weeks. This means as of 48 weeks, as of 1 year of letermovir, and then 12 more weeks after therapy to see what happens once we stop letermovir. So basically, we have 2 visits before we start the intervention, mostly because we want to make sure that we have at least 2 baselines for some of the markers that might fluctuate, so that we can have more precise measurement, and then we have week 4, 8, 24, 26, 48, same reasoning, like because this is our primary outcome, we wanted 2 visits so that we can have more precise measurement by averaging 2 very close one, and then 52 and 60. What are the objectives? So our primary objective is reduction in soluble TNF receptor 2, which, as I told you before, it seems to be a very important biomarker associated with non-AIDS event. And then we have a lot of secondary objective. Of course, if we do such a big study, we want to make sure that we look at everything. So we look at safety and CMV shedding and development of resistance and metabolic and neurocognitive and microbial translocation and T-cell dysfunction and reservoir. And some of these will be sub-studies. They will not be mandatory, and we will have to apply for external funding because the ACTG, of course, is not paying for all of this stuff. And here is the study design. So basically, there will be a screening. We will look for people that are CMV seropositive on antiretroviral therapy suppressed. We stratify, and this is important. We want at least 1/3 cisgender women and 1/3 of people with low CD4 T cells, lower than 350, while we realize that this makes overall enrollment more complicated. We feel that is important, first of all, because the previous valganciclovir study, most people had a very low CD4 T cells, and so we want to be able to compare the data, because if we only take people with high CD4 and we don't see anything, then we don't know if it's just because the effect is not so evident in people with high CD4. And same for cisgender women. It's well known that there is a sex-based difference in viral infection, and so we really want to make sure that we capture it. And I will talk about that a little bit later, but basically how we plan to do it is probably that we will force sites to enroll at least 1 women and 1 low CD4 T cells before we give them more slots to keep enrolling. So key inclusion criteria, I kind of already told before: co-infected with HIV and CMV. Okay, you know what? I told you 18 before, but in reality it's 40, and now I tell you why. Now I remember the SASC made us change that on the last iteration, because they were afraid that younger people might not have enough CMV going on and CMV-specific T cells and end-organ disease and inflammation to see a difference. So they kind of wanted us to focus on a population that was more likely to have inflammation. Sorry about that. It just came to my mind right now because that was the last minute change from the ACTG. Yeah.
Do you consider stratifying or even selecting people at a higher level?
So the question is that if we considered selecting people that have higher level of inflammation, as I think that this is something that we did discuss. We even discussed to select people that have CMV shedding, but then we decided against it because it just was making everything so much more complicated. And then I can't remember if there was another reason, but we talked about it and we decided against.
Just to remember, I remember that we talked about it a lot. There was a lot of complications with the study design if we did that. And the other one was we had a really nice normal distribution. So if we actually randomly just selected people, we should still get the high and the low people with inflammation.
Thank you. I forgot about that. So we have quite a bit of exclusion criteria. I don't want to go over all of them because that's very boring. I think that what is important to know for those of you that will eventually enroll, because I, of course, trust that we will be a very top enrolling site, is that we cannot co-enroll in Reprieve, unfortunately, because there are interactions between the statin and letermovir, and I know that will make it even more complicated. And then some of them are the usual exclusion criteria. And then, of course, we have a particular attention on the atrial flutter and flimmer, and we will not be able to enroll anybody with cardiovascular disease or any history of tachycardia. Stratification, I already mentioned. We stratify by gender, and I say gender. We spent quite a bit of time talking about it. And if anything, we actually changed the template to make it more gender inclusive. We are in this particular case interested in cisgender women because we know there is a chromosomal effect on viral on viral response. But of course, we are interested in opening the study to all genders. So we will make a particular effort to enroll people of all gender. And so this is why we are gender inclusive. And so I actually changed the template, the actual dates template because first of all, I didn't like that they were saying women of reproductive potential. That's wrong. Not only women have reproductive potential, and not only women have a vagina. So we say person assigned female sex at birth of reproductive potential. Same, the original template says women and men age 40 and higher. I changed it to individual. I think that the ACTG made this because they wanted to be inclusive of both sexes, but of course now they introduced an unnecessary binary sex variable. And then parent to child transmission instead of mother to child transmission. So I'm particularly proud that after noticing this and making all of the changes and pass it through our wonderful transgender community advisory board, I was invited to present it to the ACTG, and they are considering changing the template to make every study that is funded through the NIH, not only the ACTG, but because the template comes from dates, more gender inclusive. So that's great. Thank you. Okay, so the letermovir study has a futility analysis. This means after the 40th participant is enrolled and has reached 8 weeks of follow-up, we will stop enrolling for a while. So these 40 people will still continue on letermovir, but we will be stopping enrollment and do some stats to make sure that there is an effect, so that we don't start the big study if we already know the intervention is futile. And then if everything goes well, we will reopen the study, and then we will start doing all of the sub-study with the lumbar puncture and the PET-CT and the PET biopsy. But because the study has become such a complicated interventional study, the ACTG wanted to make sure that the intervention was working. And then, of course, there are a million other reasons why we will want to stop the study. If we have a lot of resistance to letermovir, if we have more than 4 participants who develop atrial flutter or fibrillation, if we have a lot of adverse events. That's pretty standard for trials. But in any case, we will have a hard stop after 40 people, which is actually perfectly timed because the ACTG is up for renewal, and I hope that we will be able to reach the 40 people before the current ACTG is running out, and then we can restart on the new cycle. So it looks like it's worked out perfectly. So we anticipate, if everything goes well, which you never know because the ACTG is not the easiest to navigate, but October 2019 is when we think that we will have the protocol ready for the field, and then January 2020, I think it's a little bit conservative. I hope it will not take 3 months to implement the study. And then we aim to complete enrollment in 2 years. Probably we will have the futility analysis 3-4 months, then we stop, and then we restart, and then I think it should be an easy trial to enroll, except for all the stratification and the sub-study. So no, that's probably not a very easy trial to enroll, but we believe it's a very important trial to do. Any question about the letermovir one? Yeah.
Sir, I might have missed this.
Yeah.
Very nice study. Did you mention in the exclusion criteria use of anti-inflammatory medications or chronic inflammatory conditions like rheumatoid arthritis or SLE?
Yeah, that would be exclusionary, yes.
What is Scott going to be looking for in the LP? Is he going to be looking for drug levels, CMV DNA?
All of it, yeah. We will
Okay.
look at CMV DNA, we will look for drug level, and we will also look for inflammation like CD163
Okay.
and neurofilament lights, which are a biomarker of neurodegeneration. And then we will do very comprehensive neurocognitive testing and mood disorder testing too.
Did you consider 60 weeks LP also?
Sorry?
60 weeks LP also, because you're doing one before you start the drug at 48 weeks. How about at 60 weeks after you stop the drug to see whether there is no?
Yeah, no, we didn't plan that. So I think that will be a good one. I do have to say we had to fight a little bit with the SASC to even get the 3 sub-study, because there was a lot of complaint that we were making everything too complicated. And so I think that we were trying to be conservative, but I think that an LPS, I agree with you, that will be super interesting. Any more questions? Yeah.
Have scans at all the sites or subsites?
So after the futility analysis, we will want all of the sites, because otherwise we don't have enough, because we need to have a reasonable sample sites. We need 92 PET scan. And so with the sample size of 140, and I take 40 away, we have only 140. So we probably will limit to sites that has the capability to do PET scan, and then we assume some people might not want to. But I think that after the futility analysis, we will want to decide to commit to participate to at least 1 sub-study. And possibly everybody will have to do the PET scan.
No sites.
Yeah, from those sites, and I don't know the number from the top of my head, but enough that made us very positive. And so Amei Tavako has another PET-CT study on the field right now, and it's working well. And it looks like everyone that participated in his study is willing to do it again. And so we did query the site, and even if I don't know the number from the top of my head, it looks like most of the sites would be participating, even if we force them to do the PET-CT. So we're not yet completely 100% sure about it, because it's, as you can imagine, it's very complicated. But what we think right now is during the futility, because we have no sub-study, we will give 2 slots to the sites, and they will have to enroll in the first 2 slots either a women or a low CD4 T cells. If they do a women and a low CD4 cell, that they get a free slot. If they enroll only 1, they will get 1 more slot, and then they will have to enroll. Basically, every 3 slots, you need at least a women and a low CD4, or a women with low CD4. That counts double. Then after the futility analysis, every site will have to commit to participate to the cardiovascular sub-study, the PET-CT sub-study, and at least 1 of the other 2. I think that the other 2 will make it very site limited, because we will have to train. Like, for example, the neurocognitive functioning, I think that will be a site for sure, because Ron and Scott are the co-chair of the neuro-TSG, and we have a lot of experience here. And then we will probably cherry pick some sites that we know are interested, but we only want 40 people. Same for the metabolic sub-study. Vanderbilt, John Cote, who is the promoter of the metabolic sub-study, he is at Vanderbilt. They do fat biopsy like routinely. They even go around and do fat biopsy. It's so easy when he explains it. It's like a 5 minutes intervention. He's willing to go and train like 5 sites, and then every site will have to commit to enroll, I don't know, 8 patients, something like that. But it will not be an easy study to enroll. Yeah, there will be a relatively intense neurocognitive assessment at entry week 48 and 60. And then the lumbar puncture, as it is right now, we only plan 2, 1 at entry and 1 week 48. I would love to do 1 at week 60, but we might want to discuss about that. I think we were lucky enough that ACTG has committed to fund the neurosub study with ACTG money, which is first. We are very excited about it. The PET-CT, we do 2, and the adipose tissue, we do 2. As you can see, we cannot do the PET-CT and the adipose tissue on the same day. We want to do the adipose tissue after the PET-CT, because we don't want to create inflammation by poking in somebody's fat. And these are basically the objective. I keep them very short. Cardio, the imaging sub-study, reduction in aortic inflammation. We will have to write an R01 for that one. Peter Hunt and Priscilla Shu are working on it. And I think we could have something submitted by September, and hopefully we will get that funded. The PET study, that's Merck funded. Merck agreed to fund it. We still need to finalize the process to submit the grant, but here we will be looking at the infiltration of CMV and CMV-specific cells in PET before and after. And then the neurology study, as I said before, is ACTG funded, and we will be looking at various markers of inflammation and neurocognitive in the cerebrospinal fluid. So while these are pilot studies, they are probably not powered to see a significant effect, but if the intervention works, and we are confident it will, and then we will move up to a huge multi-site study, international, where we treat a lot of people and we look for end organ disease. This pilot study will inform how we want to do that. Okay, and now let me go through we still have some time, but let me now talk about 5355. This is a kind of similar study, but instead of using a drug, we use a CMV vaccine. And the reason why, and CMV vaccine, basically we have been trying to develop a CMV vaccine since decades, because not so much for people living with HIV, but because CMV is a very deleterious infection for pregnant women and also in transplant patients. And so you can imagine that having a vaccine against CMV will be a huge public health improvement. And the reason why we are doing both studies in parallel is because while the letermovir is likely to work because it's a drug and it has a direct effect, if the vaccine works, it will be much more powerful because we can vaccinate a lot of people. We cannot put everybody on letermovir for their entire life. And so Don Diamond, who is a scientist at City of Hope, he worked his entire life on this vaccine, who is an MVA-based anti-CMV vaccine. It's manufactured by Haloxide under the name of Triplex. It encodes 3 full-length CMV antigen, and I have here, for those of you who are interested, but I'm not going into the detail of explaining how it works, just as the structure of the vaccine. But this vaccine has showed excellent safety and efficacy in both phase 1 and phase 2 clinical trial in the setting of bone marrow transplant. So these are the data from triplex in bone marrow transplant, and with the probability of CMV reactivation, there was also a decrease in mortality. And these data are brand new. They were just presented as an oral at the transplant meeting. So this is a phase 1, double-blinded, randomized, 2-to-1. This means 2 patients will receive the vaccine and only for every 1 patient that receives placebo. It's a multi-center study, again, US only, for logistical reason, because the vaccine is not very stable and we have to ship it around. This is a smaller study, only 90 people. They all need to be HIV and CMV co-infected. And here, because it's a vaccine and it's a pilot study and we need to make sure there is a response to the vaccine, we will limit enrollment to people between 18 and 65, because we know that as people age, the response to the vaccine decrease, and also people that have at least 250 CD4 T cells and the nadir not lower than 100. Again, because we know that people that had a compromised immune system just respond worse to vaccine, and we want to make sure to see the best effect possible. So this vaccine study has a longer follow-up. We will follow people for 96 weeks. This is because there are some concerns, which I actually think is a little bit of an overreaction, that the vaccine is associated with cardiovascular disease. That's been a point of controversy between the study team and the ACTG leadership. But I think that it doesn't hurt to follow people long enough to make sure that everybody will be okay. And we are only doing phone calls after a certain point. So it's a 2 vaccine. One is a week 0, 1 week 4, and then we follow people for 92 weeks post-vaccine. So so here the primary outcome is safety. And just to be clear, this vaccine has been given to hundreds of stem cell transplants. They have a study right now going on in children. So we do not expect, and stem cell transplant people are much sicker than people living with HIV, and they had basically no adverse events that were associated to the vaccine. So I am I really don't have any concern about safety, but because it's such a new vaccine, safety will be our primary outcome. And then we will look at the immunogenicity. This means how the body generates CMV-specific T cells after giving the vaccine. And then again, inflammation, same soluble TNF-alpha receptor 2. And then we have, again, multiple exploratory endpoints, which I'm not even putting on here. Some of them will be supported with external funding. This is the schedule of evaluation. So we will have a screening and then vaccine at day 0 and day 4. We will call every participant with us after a couple of days to see how he does. Every participant will have a diary where every day they will have to write down if they have adverse event. Like, we do not expect anything more than just, like a local redness like you will have from any vaccine, basically. And then we will have visits, and then we have follow-up visits at week 8, 12, 24, 48, 72, and then a last phone call at week 96. The key inclusion criteria I already mentioned before are similar to the letermovir, except for the H and CD4, and then Reprieve co-enrollment is allowed here as long as they are on stable medication. And then key exclusion criteria, again, relatively standard. You cannot co-enroll people in both studies, just one point. And we do the same stratification by gender. We do not stratify by CD4, but we also here we want 30% of cisgender women, but we are gender inclusive, and we will make sure to particularly outreach to the transgender community. We have no futility analysis here. We will have ad hoc, of course, safety review if there are, if any worry raises that we have too many adverse events or virologic failure or any reason to stop it, like any standard study. So I hope there are some issue right now that basically the protocol is ready to go. There are some intellectual property issues with the company that we are about to hopefully solve, maybe. So if everything goes well, we should have a very similar timeline as the letermovir, so that the two studies might hit the floor together. Okay, thank you so much for being here. And any more questions about the vaccine study or the sub-studies? Okay, then happy Friday.
Sara?
Yeah, oh yeah, somebody.
Hi,
yeah?
It's Scott Latender.
Oh, hey, Scott.
Hi. Did you speak to a sex effect? Is there much evidence of a sex effect for CMV or no?
What is the question? A sex effect for CMV? You mean biological? No, you cannot say biological sex. A sex assigned at birth? Is that what you mean? Yes, there is one. Both in terms of, we know that women are more likely to get infected and they have a bigger immune response to viruses in general. Yes. Actually, I think you gave me the paper once showing that women had more, women and MSM. It might have something to do also with insertive sex.
So you mentioned about enrollment of women, but the studies will look at carefully at the effects, right? Stratified by sex. Yeah.
Yes, we will be looking carefully at the effects by stratifying by gender. I know it's confusing. It took us a 2-hour discussion to figure out how to do it, but yes, we will carefully do it. Thank you, Scott.
Yeah, great job.
Thank you.